In this video, we describe the prevention of endometrial cavity entry during a laparoscopic myomectomy using methylene blue for uterine cavity distension. Leiomyomas or uterine fibroids affect 35 to 70% of all reproductive age women. 5 to 10% of infertile patients have fibroids, and fibroids that impact the uterine cavity are associated with infertility. In addition to infertility, fibroids can cause pain and heavy uterine bleeding. Fibroids may also impact assisted reproductive technologies success rates, and patients with infertility have a 50 to 60% chance of successful pregnancy after myomectomy. Preoperative imaging can assist with understanding fibroid number, size, location, and characteristics. Transvaginal ultrasound is typically used as the initial imaging modality due to its low cost, accessibility, and minimal side effects. This ultrasound shows a 7 cm fibroid in both the sagittal and transverse plane. MRIs are particularly useful when more detail is required, such as in the diagnosis of a large or multifibroid uterus, or to identify a distorted endometrial cavity. MRIs are also useful to identify possible adenomyomas or leiomyosarcomas. This MRI was particularly useful for surgical planning in the setting of a large fibroid uterus, and this MRI was useful for endometrial cavity identification. 5 steps of the laparoscopic myomectomy. Step 1 is prophylactic hemostasis with vasopressin or temporary ligation of the uterine blood supply. Step 2 is deciding on the best incision location. Step 3 is to identify the fibroid plane and dissect the fibroid from the uterus. Step 4 is to inject methylene blue into the endometrium. And step 5 is reapproximation of the uterine layers. This intraoperative footage demonstrates the use of a Williams cystoscopic needle to inject dilute vasopressin around the uterine blood supply and along the incision site. Another method to help minimize blood loss is the temporary ligation of the uterine arteries and utero-ovarian ligaments, as shown in the surgical footage. Next, an incision is made around the myoma and carried through the tissue of the fibroid. The incision was extended to facilitate with the extraction of the myoma and identification of the best surgical plane. Circumferential sharp and blunt dissection, as well as electrocautery and traction and countertraction with a single tooth tenaculum were all used to achieve an avascular plane. When approaching the suspected endometrial cavity, blunt dissection was utilized to avoid trauma or thermal damage to the endometrium. Injection of methylene blue through the uterine manipulator can help with identification of the uterine cavity, facilitate dissection, and reveal inadvertent endometrial entry. Installation of methylene blue is used periodically throughout the case to help highlight the endometrial cavity. Careful blunt and sharp dissection is used to remove the fibroid. A final intrauterine injection of methylene blue is performed to reveal an intact endometrial cavity by lack of methylene blue spillage. In the last step, the myometrium is reapproximated using a barbed suture in a running fashion from the deep to superficial layers. Care is taken to ensure that the suture does not involve the endometrial cavity. The serosa is reapproximated in a running fashion using a baseball stitch. Postoperative evaluation of the endometrium. This surgical footage demonstrates the endometrial cavity after the laparoscopic myomectomy was completed. No defects or suture were noted within the endometrial cavity, and some methylene blue staining was noted at the fundus where the myomectomy occurred. Prevention of intraoperative involvement of the endometrium is desired to minimize the risk of intrauterine adhesions, which can impact future fertility. This intraoperative footage demonstrates inadvertent entry into the endometrial cavity and its subsequent repair using 2O monocryl non-barbed suture in a simple interrupted manner. The benefits of endometrial reapproximation need to be weighed against the risks of increasing intrauterine scar tissue when assessing if endometrial closure should be performed on a case-by-case basis, especially if the patient desires future fertility. In conclusion, fibroids are a common cause of abnormal uterine bleeding and infertility that can be managed with the laparoscopic myomectomy. Intrauterine injection of methylene blue can assist in prevention of entry into the endometrial cavity. Currently, we could not find any studies or recommendations on closure of the breech endometrial cavity during a myomectomy, and data from closure during cesarean section is mixed. This is one area for potential future research, and repair of the endometrial cavity during inadvertent entry should be performed on a case-by-case basis. Thank you for your time watching this video.